Hola, buenos días. Muchas gracias por invitarme a hablar en China. Estoy muy agradecida a los organizadores por invitarme. Y voy a hablar sobre la utilidad de los emollientes. The rest of my presentation is going to be in English, but I am delighted to be here as I am half Spanish. These are my conflicts of interests. So the first thing I want to talk about is the association between food allergy and atopic dermatitis. You're probably all familiar with the Health Nut study, which was a large Australian cohort of infants that were followed up to assess the level of eczema and food allergy in the general population. So these were almost 5,000 children. And what I want to highlight today is the increase in food allergy in those children with atopic dermatitis or eczema. So if you compare those without eczema, the rate of food allergy is 4.1% versus those with eczema, it's 20.9%. And you can see similar patterns for one food allergy, two food allergies, egg white allergy, peanut allergy, and sesame seed allergy. So we know from our clinical experience that children who have food allergy generally have a history of eczema, particularly early onset severe eczema within the first 3 months of life. So I'm going to be talking today about some of the factors in the skin that are predisposing towards eczema, some of the environmental triggers, and how this potentially can be affected by using emollients. So in this diagram, you can see the baby with the red inflamed skin. You can see that the top layer of the stratum corneum is broken and has no intact keratinocytes. So you have epicutaneous damage and through that, potential sensitization. This results from a combination of factors. The first is the genetic factors, and we know a lot about the filaggrin mutation, which forms the cement in between the keratinocytes and enables them to flatten down. And if you have a mutation of the gene filaggrin, you have less filaggrin protein in your skin, which means that those breakdown products don't become the nice cement for your outer layer of the skin. There are other forms of genetic mutations in loroquine or SPINK5, which are other epidermal differentiation complex genes. And if you have mutations in these, you can also have damage to your skin barrier. Then there are a number of environmental factors. So for example, those in the home, like detergents, such as those that are used for bubble baths or in the washing machine, or in the dishwasher. These are all known to break down the skin barrier. There are certain high pH creams, even now, that are used in newborn infants that then will lead to increased protease activity and decreased ceramide production of the skin. And again, that leads to epicutaneous damage. Then there are multiple pathogens such as viruses, bacteria, in particular Staph aureus, and fungi, in particular Malassezia, which are associated with eczema and with breaking down of the skin. We know that children who have eczema don't have the same type of innate immune system. For example, they don't have antimicrobial peptide in the skin, so they are unable to clear the skin of these pathogens, which is why it's so important to have a good eczema regimen to do this for them. Then in addition, more new data has come out that there are other things in the environment that are potential triggers for sensitization and allergy, and one of these is environmental exposure to peanut. This is a summary slide of some of the work that has been done by myself in my PhD and with others as well. So we know that if people eat a peanut butter sandwich today, that tomorrow there will be a lot of peanut butter or peanut protein in their bedding and in the dust. And this can be quantified and is biologically active in terms of its interaction with allergy cells such as basophils. We also know that peanut allergen levels are strongly correlated with household peanut consumption, and that a baby's crib and their play area will have high levels of peanut if either of the parents is eating peanuts, even if the child is not eating peanuts. And we know that within the home, there are generally either higher or lower levels of peanut throughout the whole home, so it spreads around. And then finally, there has been some data looking at exposure to peanut allergen in the dust. And they showed, well, in the COFAR study, in the MAST study, and in the BANSI study, that exposure to household dust with high levels of peanut protein increased the risk of peanut allergy, especially in children with eczema or the filaggrin mutations that I just mentioned. These are some of the pathways that have been hypothesized that potentially lead to food sensitization and allergy. So I've mentioned the environmental pollutants, detergents, infections, and genetics that can all lead to an impaired skin barrier function. Thereafter, this in itself leads to dry skin, and we know from recent data from Denmark that actually just dry skin on its own increases the risk for food sensitization and allergy. But this can also, just having an impaired skin barrier function, lead to skin inflammation, because a lot of the irritant reactions then drive inflammation of the skin. And then you have clinical atopic dermatitis. The hypothesis is that through exposure to food allergens in the environment, this then leads to food sensitization and allergy. So there are two different hypotheses with skin, which is inside out, where the immune system leads to breakdown of the skin barrier, versus outside in, where allergens and microbes and a predisposing genetic mutation can then lead to a barrier defect, which in turn leads to an immune defect. And in fact, we know that there is a cycle of these, because if you have the filaggrin mutation, then you'll have an impaired skin barrier, but also, even if you have normal filaggrin genetic makeup, if you have inflammation of the skin, that will downregulate the amount of filaggrin in the skin. So this is a vicious cycle of a skin barrier impairment and inflammation. So the topic of my talk today is about the utility of emollients. And this is a simple schema where, wouldn't it be wonderful if we could just apply moisturizers from birth in infants and then prevent them from having the skin barrier defect, and therefore also prevent them from getting clinical atopic dermatitis and prevent them from getting food allergy. So there are large studies that have now looked at this based on very promising pilot studies. I'm going to spend a bit of time talking about two particularly large studies that were well conducted. The first is the Barrier Enhancement Eczema Prevention Study, or BEEP, which you are probably aware of, that was conducted in the UK. These were 1,395 infants with a family history of atopy, and they had double-based gel or dipper-based cream, which were chosen based on the pilot study, which had a preference for parents to use these two creams. They asked parents to apply this onto their child's skin from before 3 weeks of life until 12 months of life, 3 to 4 times a week. There was only a 51% adherence to this intervention, which is very common in all of these emollient studies, that the adherence is rather low. Unfortunately, the study found that this intervention did not prevent, delay, or reduce the severity of atopic dermatitis. In fact, there was a chance that there was a trend towards an increase in food allergy, and there was an increase in skin infections, which was statistically significant. And this may be because parents were not washing their hands prior to applying the creams onto the skin. These are the study results. You can see that the primary outcome was the UK Working Party diagnosis of atopic dermatitis at 2 years. So in the preventative emollient group in blue, the rate of eczema at 2 years was 25% versus 23% in the control arm. There was no difference if you looked at the parental report of the UK Working Party diagnosis at 1 year, and similarly at 2 years. Then importantly, they also looked at skin prick testing of 3 millimeters or more at 2 years to milk, egg, and peanut, and there was no statistically significant difference. And then they looked at the difference in food allergy to milk, egg, or peanut at 2 years, and they showed that there was a trend favoring the control arm, i.e. the children in the preventative emollient group had slightly more food allergy, 7%, versus those in the control arm at 5% that were not advised to apply a moisturizer from birth. Now, the PreventADAL study is another large study that was done in Scandinavia. This was a large study of almost 3,000 people from the general population. And it was a 4-arm study looking at not just emollients and restoring the skin barrier, but also doing first tastes of food. They used a paraffin-based bath oil additive, and then they used an alcohol or paraffin-based face cream called Ceridal. They asked the parents to use this from 2 weeks until 9 months of age, 4 days per week. And the adherence in this study was even lower at 27% adherence. Now, peanut, milk, wheat, and egg tasters were given from 3 months of age. Importantly, in this study, they did not find any difference in skin infections. And these are the results of the PreventADAL study. So in atopic dermatitis, you can see here that there was actually a trend towards the intervention increasing the incidence of atopic dermatitis. There was no significant impact of the food intervention. And the PAD is just the parental reported atopic dermatitis. Now, these studies were looked at back in 2021 by Maeve Kelleher in a systematic review to assess whether there was any benefit of preventative emollient therapy in children without eczema yet. So you can see here that the Chalmers paper in 2020 is the BEEP study, and the Skirvin paper in 2020 is the PreventADAL study. So overall, you can see that the forest plot shows that there is no significant difference, with a risk ratio of 1.03, and the black diamond is right in the middle of 1. However, since then, there has been a little bit more work looking at this. So the question in this new meta-analysis, which I'll go into in a bit more detail, wanted to find out whether prophylactic emollients from 6 weeks of life onwards was able to prevent atopic dermatitis or food allergy. And they looked at it in a slightly different way. So they had 10 randomized controlled trials, and 6 of these had continuous emollient application up until atopic dermatitis was assessed. And 4 had an interval between cessation of emollients and atopic dermatitis assessments. 10 had a primary outcome of atopic dermatitis, and 4 had food allergy outcomes. They also looked at high-risk populations versus the general population. And they found that in the high-risk population, there was a reduction in atopic dermatitis with a risk ratio of 0.84, and that in continuous application of a moisturizer versus not the interval between cessation and AD assessment. So if the children continued to have moisturizers applied until they were assessed for eczema, there was a reduction in atopic dermatitis with a risk ratio of 0.59. And there was no change in food allergy sensitization. So this is looking at this data in a little bit more detail. This is a high-risk population with preventative emollient therapy, and the outcome was atopic dermatitis. So you can see here that the subgroup for 6 months had a risk ratio of 0.55, which favors the emollients. The group of 6 to 12 months had a risk ratio of 0.62, which also favors the emollients. And the subgroup of 24 months had a risk ratio of 0.92, which did not favor the emollient, which was on the level 1. But overall, what this is showing is that using the duration of the emollient application and assessment time, there's actually a difference depending on when you assess the eczema and how long they've had the emollients applied. And then the interval between cessation of treatment and assessment of atopic dermatitis was a really big one to think about. So you can see here that in the group that had an interval between cessation of treatment and assessment, the risk ratio was 1.11, which actually was going towards favouring standard care, but was very much non-significant. However, if you looked at those where there was no interval between cessation of treatment and assessment, there was a trend, there was a significant favouring towards the intervention of 0.59. So in this study, it essentially showed that there was probably a delay in the development of eczema rather than not having any effect whatsoever. So what can we talk about when thinking of getting children who already have eczema? Because the studies that I have shown were all in children who did not yet have eczema. What about if we find children that have eczema and we treat the eczema, can that prevent food allergy? So in this study that they looked at, unfortunately, there was no impact of preventative emollient therapy on food sensitization. So this was in children that did not yet have the impact, have eczema. However, there are other studies which I'll talk to you about in a few moments that are looking at that. Now, this is a really interesting study which looked at the development of food allergy in the Inquiring About Tolerance study. So this study was a large study from the general population, which assessed whether early introduction of food allergens could prevent the development of eczema, of food allergy. And they also collected a lot of qualitative data. So they looked at how often children were being moisturized when they were first entered into the study at 3 months. And this analysis was done following the findings that there was no benefit of applying moisturizers from birth to prevent eczema or food allergy. The question was why this might be the case. So what they found was that children who had more than daily application of moisturizers by 3 years of age, at 3 months of age, were much more likely to have food allergy by 3 years. So you can see here that in children that never had moisturizers applied, the rate of food allergy was around 1 to 2%. In those, however, that had over daily food moisturizers applied at 3 months of age, they had a rate of food allergy of 33%. Now, when they drilled down into this in a bit more detail, they found that there were many children without eczema that were getting moisturized, mostly for baby massage. And then there were also those who were having eczema who were getting emollients applied. So 70.7% of children with no eczema had moisturizers applied, and 89.7% of those with eczema had moisturizers applied at least once a week. What were the moisturizers that were being used? You can see here that both for children that had no visible eczema and those that had visible eczema, the most common moisturizer was olive oil. And we now know that olive oil actually disrupts the skin barrier. Then on those without visible eczema, there were other Johnson's baby oils, E45, Johnson's baby lotion or Latum, and aqueous cream. And we know that aqueous cream has got SLS, which disrupts the skin barrier. So perhaps it was because of the type of moisturizer that's being used. Now, the authors looked into this in a lot of detail because they were surprised at the finding. They wondered, was this finding due to a dose response between atopic dermatitis severity and moisturizing frequency? So they thought, well, if the child has severe eczema, they have more moisturizers, and then obviously they'll have more food allergy. But they adjusted for eczema severity and for filaggrin status and still found the same effect. Then they looked to see whether infants who had moisturizers applied had eczema or dry skin before enrollment. But actually, this effect persisted even when infants whose parents reported eczema or dry skin were excluded. Then finally, they looked to see whether certain moisturizers might be damaging the skin barrier. What they found was that transepidermal water loss increased with each application of moisturizer. Now we know that olive oil was the top moisturizer applied in all children. And we now know that olive and other vegetable oils impede the development of lamellar structures of the skin. And I've already mentioned the aqueous cream disrupting the skin barrier. But also, oils potentially could be facilitating transfer of allergen to the skin. And we know that in mouse models, oils facilitate the penetration of model chemicals. So going further into the type of moisturizer, so we know that there are mostly petrolatum-based moisturizers available for children with eczema. This was a study, one of the pilot studies before us getting the SEAL study grant, which I'll talk about in a few moments, where we looked to see whether there was any difference in transepidermal water loss if you used a petrolatum-based moisturizer or if you used a trilipid-based moisturizer that contains ceramides, free fatty acids, and cholesterols in a specific ratio to mimic the skin. So in this study, we used 45 children. We recruited these children with dry skin or atopic dermatitis. They were between the ages of 3 months and 7 years. And what was very nice about this study is that we were able to ask parents to apply a different moisturizer onto the left versus the right arm, and the parents were blinded to which moisturizer they were using. So each child was its own internal control. You can see that at baseline, the transepidermal water loss was raised in these children, as would be expected, almost 25. After 5 weeks of Aveeno, which is a petrolatum-based moisturizer that also has some oat-based products, that there was a reduction in chul, but this chul would still be considered abnormal. However, if you looked at the trilipid, this particular brand was Epiceram, there was a reduction in chul down to around 8, which would be considered a normal chul. Subsequently, this type of study was repeated, but looking at some immunological markers. So in this study, there were infants that were recruited with either atopic dermatitis or dry skin. And in this situation, the whole body had either Aveeno applied or the trilipid cream applied. And then we looked at a total IgG4 to IgE ratio and peanut IgG4 to IgE ratio. And these were all in young infants. You can see that in the group that had the Aveeno applied, that actually IgG4 to IgE ratio reduced. And this is because IgE actually increased when Aveeno was applied. Conversely, if Epiceram was used, the trilipid, IgG4 to IgE ratio increased. And a similar picture was found for peanut, IgG4 to IgE. This is a pilot study called the Pebble study in Australia, which looked at applying trilipid emollients onto children that were at high risk of developing eczema, but had not yet developed eczema. They showed that there was a trend towards a reduction in atopic dermatitis at 12 months, with 16% having atopic dermatitis in the control arm versus 5% in the intervention arm. But what was more interesting was the skin prick test sensitization results, where they showed that for milk, egg, peanut, and any food, that the skin prick test sensitization was lower in those that had been treated with epiceram in the intention to treat group, but that actually in the protocol group, which was the group in which children had had the epiceram applied at least twice a day, 5 days a week, that there was no sensitization to any food. And this is being borne out in a larger pebble study. So to summarize, what do we know about moisturizers or emollients and the prevention of atopic dermatitis and food allergy? So for preventative emollient therapy, we have new meta-analysis data which shows that it may delay atopic dermatitis. The reason for that is that when I mentioned the meta-analysis where children who had the moisturizers applied up until their atopic dermatitis was assessed did show a reduction in atopic dermatitis. Whereas if there was a gap between finishing the moisturizers and then 6 or 12 months between assessing the atopic dermatitis, there was no difference. But this may be very beneficial in terms of thinking about how to induce oral tolerance induction. If you're able to increase the window of opportunity to get more foods into the diet, there's potentially the benefit of preventing food allergy. They also showed that it might prevent eczema in high-risk infants, but not in the general population. They talked, as I've mentioned, about the impact of time of cessation of treatment and assessment of atopic dermatitis. But there is the point about an increase in skin infections and a trend towards food allergy in the BEAT study. And I think that this is something that, in terms of the skin infection, needs to be carefully monitored in any future study. In terms of the type of emollient, we know that certain moisturizers like olive oil in the EAT study were associated with an increased risk of food allergy. However, conversely, we know that certain moisturizers or emollients like trilipids have had positive results for atopic dermatitis prevention and a reduction in skin prick test sensitization. And this is the pebble study in Australia that I mentioned. Finally, I'm going to talk about a study that has now commenced. We have recruited approximately 40 participants. This is the Stopping Eczema and Allergy study. It's a NIAID-funded multi-PI study with Stanford, National Jewish, King's College London, Guy's and St Thomas's, and the University of Chicago all involved. In this study, we are going to look to see whether children that already have the first signs of eczema, whether that be dry skin or eczema, can have a proactive skin care combination of emollients and topical steroids, which I haven't touched on, but there's a lot of data on the emerging data on potentially using topical steroids for the prevention of food allergy. And we will be using this in children to try to maintain a normal skin barrier function and thus prevent transcutaneous allergen sensitization and the development of food allergy. Briefly, this is the trial design. We are using 2 intervention arms, one with Aveeno and proactive fluticasone propionate cream, and one with epiceram, which is the trilipid cream, which I mentioned, and proactive fluticasone propionate cream, versus the control arm, which will be standard of care or reactive arm. We will then decide whether the trilipid and Aveeno are significantly different in their respective efficacy, and then decide whether to keep all 3 arms or to combine the 2 intervention arms. And the outcome will be food allergy based on double-blind placebo-controlled food challenge by 36 months for egg, cow's milk, peanuts, sesame, fish, wheat, and 5 tree nuts. This is briefly the schema in terms of how we will be managing their skin. Importantly, we'll be using the fluticasone propionate on the body and only from 3 months, hydrocortisone on the face, and we'll be using the proactive steroid treatment, which is when there's an eczema flare to use twice daily topical steroids up to 14 days, and then if there's recurrent flare to use twice weekly for 16 weeks. Muchas gracias por vuestra atención. I would also like to thank all of the different people that, and clinicians and scientists that I'm working with on this particular topic, that have also done some of the book chapters and reviews with me on this topic. And I'm very grateful to work with them, and I'm grateful for the invitation today to speak to you. Thank you.